Thank you, Dr. Karubi, and good evening, everybody, to this last session of the first virtual AIOS. Um, I have these two talks, so I'm going to do them one after another. They're not sort of related, but we'll see how. Well, OCT, as Dr. Karubi mentioned, is something that we are people can't live without. I mean, we know we do it day in and day out for adults. But for children, it's been rather hard because of the limitation of the technology that was available. You either had to put babies into these positions or you had to dismantle an adult OCT to make it handheld. But since the availability of the handheld OCT, things have changed. This is a normal OCT of an adult male. Could be female as well, but this is an adult, and we all are familiar with that. But if you look at a OCT of an infant, and this particular picture, the baby is born preterm, then you notice that there are certain differences. And these are important to understand because we're going to try to correlate that with CVI. So firstly, this outer plexiform layer, which is moving straight here, there is a gap between that and the inner limiting membrane. So there are inner retinal layers that have not disappeared. The other changes are, we'll see them as we go on, is the ellipsoid zone, or what used to be called the ISOS, or the photoreceptor layer, is either depleted or is present but is attenuated. Now, train your eyes on the two vertical blue arrows that you will see in every successive slide. They're going to come towards each other. So this shows you that the ellipsoid zone, or the ISOS, is going to come towards each other, which means it is beginning to grow as the baby grows older. This is a preterm baby born and postnatally at 42 weeks, 46 weeks, 47 weeks. And that's when it becomes a bifid layer or a two layer. This basically means that all preterm babies are not born with all layers. And it starts happening after a few weeks or few months. But what's really important is, can we correlate any of these OCT events with vision? So that was part of what we've been doing here. And this summary on top, the table on top, shows you that there are certain layers, and these were all compared in all preterm babies, some who had ROP and some who didn't. And we found that ROP actually delayed some of these layers, although ophthalmoscopically their maculars looked normal. So they looked like they had a normal retina, and they were all, in fact, in this group, some of them had not even received treatment, but they had these layer abnormalities. So to summarize what they had abnormal, they had the inner retinal layer fusion not happening, a late development, arrival of the external limiting membrane, and the ISOS that we saw. And we correlated that every 3 months up to 1, and now even 1.5 years. I think Dr. Karubi spoke about how Downs is also part of the CVI spectrum. We started seeing a lot of patients with Downs, and we were interested in examining their OCTs. And what we found here is that even the older Downs child, who is more than 2, 4, 8, 10 years old, had these persistent changes in the OCT that mimicked a preterm baby. And while these changes mimicked a term baby under 2 years, after 2 years of age, the Downs children seem to have persistence of the abnormal layers, whereas the term controls, who are non-Downs children, they started developing the normal layers. So this again mimics what is happening in their neuroanatomy, and we know that the tangles and all the changes that happen in the CNS actually worsen after the age of 2. So some, in a strange and interesting way, what we are noticing in the inner retina is actually mimicking what is happening in the brain as well. Now, while we were looking at these preterm babies and trying to image their ridge, we sort of almost serendipitously walked into this finding here, where we found a macular edema of prematurity. We were the first group to report that. So at that time, there was no nomenclature. So we decided to classify it as two patterns. In pattern A, there was a complete disruption of the foveal dip. And in pattern B, there were these foveal and parafoveal hyporeflective spaces in the inner retina. And the B picture on the right are the same babies after a few weeks spontaneously resolving. These were not treated in any form, not even with topical drops to sort of reduce the edema. And it turns out that it just could be a physiological variation of inner retinal changes. But then what's really interesting is this pattern B, which is not just the foveal or the subfoveal hyporeflective spaces, but the parafoveal as well, started, and the Duke group was the first to report that. They correlated that form of edema edema with cortical vision impairment. Coming back to our own cohort, we followed up these babies, the ones who had the edema, ones who did not have the edema, and ones who did not have ROP. And we found that those who had the edema, even though it was transient, did have vision delays, and we were checking this using teller acuity and comparing it with the age match nomogram. They did have a drop in vision, which only made up by the end of 1 and 1.5 years. Now, coming back to the Downs and the CVI syndrome, this is a very famous lecture by Gail Morton, where he says that no child in his large career of looking at these children has ever had a 20/20 vision, despite having corrected refraction, amblyopia correction, and even normal macula. What's really important then is, are we looking at the subclinical changes now picked up on the OCT, maybe down the line on the OCTA? Are we looking at subclinical changes in these babies that can actually explain why their vision is so-called not 20/20, or is it part of the CVI spectrum? So OCT, we have now moved on to examining a whole lot of spectrum in foveal hypoplasias with syndromes, MPPC syndromes, IP, rubella, infections, tumors, and so on. And the important thing is correlating it with their systemic findings. So this is the Duke finding, where they've correlated the pattern B-like parafoveal hyporeflective changes and the supra-OPL outer plexiform layer hyporeflective changes with, in this case, hypoxic ischemic encephalopathy. And these are the patterns of edema that have been shown. And these are, as you can see, distinct and different from the ones we found in the macular edema of prematurity, which is more exactly subfoveal, and there is a disruption, and that's that on the right. There's a disruption of the foveal dip, and it looks like cystoid macular edema that we are so often see in adults after surgery or inflammation or uveitis. So there are these patterns now, and this is being correlated with MRI findings in the brain, both for hypoglycemia, for birth asphyxia, for hypoxic ischemic encephalopathy. And this is to summarize the changes that you find in changes in OCT with HI and those that are not with HI. We have been using OCT, for example, here in this case, where children have get referred back to us from our pediatric ophthalmic colleagues who have tried everything possible for the amblyopia management to see if their vision improves. And when we look at their OCT, they just have these photoreceptor changes. They don't have dystrophies. Here's another example. One eye moves to 6/6, the other eye does not improve despite patching for a 7-year-old with 6/18. And then look how different their OCTs are. Look at the outer retina, look at the ellipsoid zone, how thin and attenuated that is. We don't know the cause of why this happens, but these subclinical changes might be able to explain what we are seeing. So that's as